Hi, everyone. Good morning. And thanks for joining us this early morning.
Just squeeze in here.
So I want to pour a little fire into Charlie's remarks. A few years ago, one of our guests up here said something pretty provocative. And let me quote it, Fred Trotter. I believe that the only way to solve the problems in healthcare is to embrace a radical openness with health data. Healthcare data, with the exception of patient identity data, belongs in the open, in the sunlight. When used correctly, I believe that healthcare data should make patients feel empowered and everyone else in the healthcare system feel uncomfortable. I believe that patients deserve deep, dangerous, and real access to data. I think when we start talking about how data might actually be dangerous for patients, it's just a sign that we're doing it right. So I want to start with Dr. Vivian Lee. We were talking backstage, and one of the things you said that the word brave, you've heard used a lot during the past few days. I wonder if you could connect the dots between brave and dangerous.
Okay.
When we talk about data.
Well, so I'm really struck by that quote because when we talk about dangerous, why does it have to feel dangerous? What is it about that data that I need to feel, or my providers, I assume is what is implied there, have to feel afraid? And what I'm struck by there is our own experience in posting data online and with transparency. We really try to reduce that level of pain because it shouldn't be an adversarial relationship between patients and providers. It should be a partnership. And so by sharing those same data that would feel so dangerous if they just popped online all of a sudden, but instead making that available to providers first, and then saying, okay, you know, in a few months that's going online, everyone's going to know about it, but we're going to give you a little time to address some of those issues first. That makes the data a learning experience rather than a gotcha. And I don't think a gotcha necessarily really advances what we all want to advance, which is better health, right? So I think allowing the providers to learn from the data a little bit will enable them to feel more comfortable with transparency, and also will enable us to help make the health system better.
Fred, what were you trying to get at when you used the word dangerous? What were you saying? What were you trying to get at?
You know, it's a good question, and thank you for not asking me about my quote first, since that's really confusing to have to you know, to figure out whether or not you still agree with what you said a couple of years ago.
Well, do you?
It's non-trivial, and you know, I think it's interesting. So I do a lot of data journalism, but as Charlie can attest, data journalism is not exactly the most lucrative stuff. So we've started a company called CareSet that analyzes the data, and I have a partner whose name is Ashish, works with me in that company. And Ashish called me one day and said, Fred, we're looking at one of your interfaces that shows some data about doctors, and we have this question, and you know, he asked me this question, which I felt like was obvious. And of course, you know, how dare you question me? I'm a programmer, you know, the programmer who designed this interface. It's beautiful, it's obvious, you know. I was somewhat offended in doing my, you know, arrogant programmer thing with him on the phone, and he interrupted me. And he said, Fred, you know, I understand this data, and we've worked together for a long time. You know, I've been doing data journalism with you. I know what the data is, and I've seen this interface before. But I'm at a hospital, and if this data is what it appears to be, we're going to fire a doctor. And of course, you know, I took a step back. I've been fired before. It's a miserable experience. I don't recommend it to anybody. And I thought, okay, you know, now the rubber meets the road. People are using my data in a way that I had always hoped. Like, ultimately, hospitals that do terrible jobs need to go out of business. Doctors that hurt people need to go out of business. You know, on the other side of that, hospitals do an amazing job, need to do well financially, and doctors who are good doctors need to be remunerated appropriately and everything else. I mean, I want the economic forces to use the data the dangerous data that I'm releasing in exactly the way that that I was experiencing. But when the rubber hits the road, it's a pretty uncomfortable decision. And so I took a second, looked at my own interface, and I said, yeah, I think this guy probably needs to go. I think there's some other examples, but ultimately, since that time, while I am a little more humble when it comes to, well, everything really, but also just specifically what can be done with data and what it's good for, I still think that's the right track. I think we need to have data that makes people uncomfortable, data that you can use to fire people, because that's ultimately, unless we get there, it's going to be very difficult to make the really hard decisions that we need to.
So Howard and Carly, jump in about, Carly, you and I have talked yesterday a small bit and today about how do you use the data? How do you make all of this data usable for patients? And we have, and Charlie has one methodology of doing so. How do you look at this avalanche of data and how to use it?
Well, it's interesting to me that the type of data we've been talking about so far this morning is informations on doctors and their success rates and their relationships with other doctors and financial arrangements and things like that. Because originally, my first thought when I think data, I think things like Hugo's implantable cardiac device, and he's trying to get his own data, and people with diabetes who are trying to get their own CGM data that they're producing that they want access to. So I didn't immediately think of what's my doctor up to. I thought of the more kind of intimate data that patients are producing, and it seems, like you said, it seems obvious. It seems obvious that, of course, we should have access to that, and why don't we? But to actually answer your question, the apps that you guys have developed at ProPublica, that's great, but you mentioned 2 or 3 different platforms, and even those, what if they were integrated? Because I have a full-time job, I have a full-time being a patient, unpaid job, and I don't have time to go through. It's great that there's these steps, but I don't have time to dig through tons and tons of extra research, and that's in the best situation. That's like, oh, I need a new dermatologist, it's not urgent, let me go do research. But if I'm taken by ambulance to the ER for a ruptured intestine, I don't have time to say, well, who is the attending's relationship, and how many reprimands have you gotten, and how much are you being paid to do this procedure on me? So making it as easy as possible. Having access to data is fantastic, and I definitely agree with everybody. But as much as we can frame it in a way that's helpful for people, meet them where they are, the people that want that 100-page report, and the people that need the sound bite to say yes or no, this is okay.
Howard, how do you see this data done?
Well, I love tying these 2 questions together, both the patient access and the question about danger. At Tidepool, we're dealing with diabetes data, specifically people with diabetes that are dependent on insulin. And insulin's a deadly drug, and people with type 1 diabetes multiple times per day need to take insulin with the risk that it could cause them to have a hypoglycemia event, potentially have a coma or a seizure, or that they could have hyperglycemia and have to go to the hospital for a diabetic ketoacidosis event. So the real danger is by not giving access to the data. People have to make dangerous decisions without having the information in front of them that they need to help effectively manage their disease. So what we're doing is saying, how can we remove those barriers? How can we help the device companies get data out of the devices and bring it together to liberate the data from the device so that patients and their doctors or parents of patients can have access to that data and reduce the danger. So I think the real danger is in not liberating the data.
Dr. Lee, the University of Utah Health System gives patients online access to a system that provides patient satisfaction scores and comments, and that began several years ago. The rankings are based on 40,000 patient surveys, I believe, and evaluate physicians on 9 questions. How did you get there? How difficult was it in terms of culture change to bring an organization? Organizations aren't particularly ever open, or ever, the amoeba is never wanting to be transparent. How did you bring them along? How was this accomplished?
Well, so I think everyone understood the line that my predecessor used, which is you can't be a great medical center if the patients don't think you're great. And all of us were really tired of hearing complaints about patients. You know, we have pride of profession, right? People want to feel like they're doing a good job. That's why we got into the field to begin with. But I think that the step that I was involved in was the online posting. Prior to that was in the previous administration. My sense of it was really, it was gradual. So no one would complain about getting their own patient satisfaction data privately, right? You get that information, it's private, you look at it, you try to improve. And then gradually we said, well, now you can see everyone else's data and they can all see yours in your division. And then gradually we said, well, the cardiologists can see the surgeons, can see the rheumatologists. And so it was very gradual. And as I said, what happened in that gradual process was, and I do understand that there are always some bad apples, so I'm not trying to defend those people, but I would say the vast majority of people are not bad apples. And so what they were able to do was to improve, and by the time we were ready to post online, we had given everyone 6 months' notice, lots of town halls, tons of discussion, believe it or not. There was a little bit of pushback. But by the time we were ready to post, almost everyone was over a 4 out of 5 stars, you know, the 4 out of the 5 score on all the Press Ganey questions. So most people could feel like they had something reasonable to share by then. And of course, we did have turnover. People left the system, physicians left, staff left. A lot of the issues were around staff, around receptionists, around people in the waiting area. We did some system-wide things that made it much easier for everyone to get better scores, like we implemented valet parking. So if you come to our hospital, everyone gets free valet parking, no tips allowed, because that was a constant complaint for everyone. Mm-hmm. So there's some system things that we try to do to also make it better for everybody. So it was gradual, but it's an example of, I think, how data transparency can work if you work with the providers to make it a learning experience.
Charlie, I wonder, as I hear Dr. Lee talk about not making this a pejorative system and data, I wonder if the data might be telling us at this particular time more about who's a bad doctor and not really about what's a good doctor or helping us define what's a good doctor?
So I think it is easier to spot outliers in the data. And one of the things we did was look for doctors that are performing quite differently than their peers and identified what is going on there. And so in 2010, we looked at our prescribing data at the top prescribers of OxyContin, the top 20 prescribers. And at the time we looked at it in 2013, 11 of those 20 had been indicted or convicted. Several more have since been disciplined, indicted, or convicted. It was a real flag that if you were on the top 20 list of OxyContin in 2010, you were doing something that was sort of aberrant. And so, yeah, so in that perspective, that is identifying a big red flag that, we're raising. To say what's good, though, is more difficult because we don't have clinical quality indicators. We have sort of counts. We have measures. And so I think the first pass, the way a patient can use it, though, is to identify, does a doctor I'm considering treat patients like me? Do they use the drugs that I'm using? Do they have experience in the services they want to provide for me? Are they making enough surgeries or whatever? Are they performing certain tests that no one else does? So that's the way in which I think patients can use it. That's not a clinical outcome, but it's sort of, is the doctor treating patients who are like me?
Let me ask other members of the panel, and then we'll go to your questions. If you could choose 1 or 2 words to say what defines a good doctor, what someone should look, what's the definition? If you get at the nub of what's a good doctor, can you do that, Carly?
I think it depends on the individual patient and what their preferences are and how they want to work with a doctor, because what's a good doctor to me might not be what's a good doctor to somebody else.
Dr. Lee, can we get to the nub of that?
I would say expertise and empathy.
So I get asked, for whatever reason, people think because I'm a programmer that I know when Watson's going to be a better diagnostician than a clinician, and I always answer that question the same way, is that people don't understand how variable doctor diagnosis is. Even there's good evidence that indicates that even between seeing the same symptoms on different days, doctors will vary their diagnosis slightly. And so I think it's their job to be right.
In the case of type 1 diabetes, which is what we're focused on right now, I believe the great doctors are the ones that engage with the data on a regular basis, not just at every 3-month appointment, but even more importantly, the ones that engage with the data and help create teachable moments for their patients so that the patients can also engage with their therapy and understand how to provide more effective therapy for themselves. You can't wait till that 15-minute appointment that comes every 3 months. It's every single day with type 1 diabetes.
Charlie, do you want?
I think I would say one that has good clinical outcomes and one who's empathetic.
How about questions from the audience? There are microphones in the audience. Who has any questions? Right over here.
Thank you. You spoke much about provider data. Patient data is one that you didn't touch on, and the openness of patient data and the ability for algorithm creators to take this patient data that you can purchase and then create filter bubbles for patients. So, for example, if you have a negative experience, you can constantly target someone with positive ads, changing. And so the negative influences of patient data and the amount that's available there and collected through patient groups. So can you comment on those?
One of the things that we do a lot of is look at aggregate data on physicians, because in some senses physicians don't have the same fundamental privacy rights that patients do. It's actually harder to get solid data on patients than it is to get solid data on doctors, since Charlie and I and others have been doing the work in the area. It is really hard for patients to donate their own data in meaningful ways, and we would really like to change that. And that's sometimes I think that, and going back to this dangerous concept, I think the healthcare system does way too much to protect the patient from problems the patient does not feel they have. You know, I've heard some amazing talks about just the John Wilbank's talk I recommend is you know, when you go into a hospital and you're naked from behind in these little uniforms they give you, walking around trying to get your problem solved, it's very, very difficult to explain to that person that they're protecting your data from researchers who could use it usefully to generate solutions for them because of their privacy rights. You know, imagine saying that to someone who was walking around this conference who was nude from behind. I'm protecting your privacy for you. Don't worry. It's a ludicrous concept when you look at it on the face of it. And I think it's a great example of how dangerous data, what we think of as dangerous, really is just good enough. So I'm very concerned that we have too much emphasis on provider data and not enough on patients.
Go back in the back of the room.
Thank you. Dr. Lee, I'm so grateful for your comments, and I worry very, very much. I'm with the Center for Patient and Consumer Engagement. I worry an awful lot when we enter this conversation about engagement from a consumerist position, and this feels like consumerism to me. So the question that I would love to know from the panel is, what makes a good partner? And that is a very different question for me, because if I'm shopping for a doctor who will partner in my health care, I don't know that obviously I want to trust that person, but I feel like there's an entirely different mechanism. So I'm curious to know, if we were not asking what's a good doctor, but what's a good health partner, would we be looking at different criteria?
I was actually really interested in what you were saying about helping the doctors improve using the data, because so often, especially if you're an ePatient, you know, people will say, well, that's not a good doctor, so you should just fire them and get a new doctor. But the more severe your illness or the rarer your disease is, you might have one doctor in the country or, you know, 2 in your state. And if you start just firing people left and right, you're going to be left with no one to work with. So I think that, you know, that is a really, you know, good program and a good point to try to, you know, improve everybody so that we have good doctors to work with.
That's a great question about partnership. And I wonder if you could expand on that, Dr. Lee, about partnership. Is that the core value of physicians?
Well, I've just been struck by this conversation on the panel, and also just by being at this conference. It's been a really stimulating experience for me. And thinking about all the talent that's in this room, that the partnership would it's fine as an abstract concept, but I think it would really gel if we would, one of the thoughts that has come to my mind is to redefine what it means to have personalized medicine. So like Amir alluded to, in our academic medical center, when we think personalized medicine, we immediately think genomics and all that. But actually what I'm kind of hearing is if we think about the personalization of the experience so that if you're a patient and you have data and you need tracker kind of data, like you're a diabetic and managing your sugars or your HbA1c, or you're going to see a provider and you want to have that data about that provider because you want to be able to select or help them improve or ask the right questions. If we were to focus, and many of you have the ability to do that, including you, on developing technology and information flow systems so that both the provider and the patient can be focused on that personalization of the experience, I think that could be really transformative and kind of glue that partnership, make us both aligned to thinking about what your personalized experience really needs to be. So that's just a thought I would offer.
Can I just add one thought? I think the one thing that's sort of remarkable is that here we are in 2014, and many doctors have absolutely no clue about what they do, how it looks. They don't get any feedback that helps them improve. And I agree with you. Doctors want to be good. That's why they go into medicine. And the fact that we're sitting here and the pharmaceutical company has all of this access to data about what doctors do. Insurance companies know you too. I mean, they know you so well, and yet doctors themselves have access to none of this. So we're talking about what patients should have access to. But it is appalling that doctors don't have access to their own information.
Especially when you consider that physicians in general are pretty good self-learners.
Right.
Right? At least between the ages of 18 to 32, they were really intensely learning. And then after that, we cut off all information and feedback for them.
Yep.
Yeah.
Before we get off the stage, I wanted to applaud the comment of solving the parking, just in general.
It all comes down to parking.
We don't have very much time here, but seriously, if you look at a social media analysis, almost all patient-centered organizations, the patients always complain about parking, so it's huge that you did that. And it speaks to, I think, something that I think we're kind of hinting at, especially that slide, one slide you showed about, you actually labeled it up, said this guy's convicted, this guy's, this is a team of people who are bad apples. I think one of the things that we underestimate when we talk about partnerships is the system. And when we have groups of doctors working together, we need to start examining them like baseball teams. And I think, we talked about the Moneyball approach to doctors, but I think that looking at them as a team is a huge part of it. It's not fair to look at a physician without understanding whether or not they're using a pain specialist or whether or not they're using another kind of physician. So we need to stop being so obsessed with individuals and actually think about partnerships as a whole as a level of analysis.
One last question.
You actually touched on exactly what I was going to talk about. I have lung cancer, and I have several doctors that I have to deal with on a regular basis. I have a pulmonologist, an oncologist, sometimes I have a radiation oncologist. Because of mutation testing, having a pathologist involved is really important. If you're dealing with pain, it's nice to have the palliative care team. And if you pick just one provider without knowing who he networks with and what resources he can bring in, you're putting an additional burden on the patient to have to be the one to do all of those connections. So for me, when I choose someone, I have to choose someone who is part of a team and has access to the resources that I need. And that would be one thing that I would find useful on your data system, is being able to find out who else that doctor connects to.
I'll give you my $50 after. Thank you for that.
Thank you very much for the panel joining us, and thank you for your great questions.